shoot. Daniel, can you, sorry, we're gonna have to now explain to him how the video situation is going to work. This is why I leave Daniel to make the links, and this time I made the links. Hamza, can you hear us? Oh, see, his video just turned on. How did that happen?
Oh, and I just made him the host, so it's probably easier that way.
Okay, well, there we are. Well, good evening, everybody. Hamza, thank you so much for joining us with your busy schedule. All of you with your busy schedules, I appreciate this so much. We're just going to start with introductions, and because I have some background noise, I'm actually going to let you guys introduce yourselves. Sorry, I'm sitting in a cafe here. But this webinar, just to kind of recollect, thank you for our attendees and viewers as well. This webinar, we've kind of designed our webinars for this month, for Mental Health Awareness Month, to obviously address this theme of mental health in the humanitarian sector. And this first webinar is taking kind of an alternative discussion point of talking specifically about the mental health of men. And so each of the panelists here, I've had conversations with all of you independently, except you, Theresa. Daniel's done a great job of finding you as a participant here. But to sort of discuss your experiences with forcibly displaced men and men from certain regions of the world when it comes to their mental health care. And so I'm going to let each of you introduce yourselves with your professional background and the NGO that you're representing, if you are representing one. And Theresa, let's start with you.
Fine. When I was working in the NHS in a very small specialist unit for complex PTSD, one of my additional tasks was to visit the Centre for Asylum Seekers in Detention at Gatwick. And so I would see people who had been referred by the medical centre they reckoned people had some psychological issues that needed, well, at the very least, some psychological first aid. So I would always take a history, and I heard a lot of very terrible stories, and it was really, latterly, it was all men, because at one point the detention centre was for both sexes, and then it became all male. So that's my main experience of the sort of people that we're talking about tonight.
Okay, Gabriella, we'll have you go next.
Hi, everyone. Lovely to meet you. I am Gabriella Brent, and I work for Refugee Trauma Initiative, which is an organization that builds local capacity to provide safe collective healing spaces for families and young people and men and women, so different groups of people. And we work with grassroots humanitarian organizations and people who have lived experience or are currently refugees and asylum seekers. We provide training and capacity building support and different collective healing practices, which we might talk more about. I am a trained counsellor and psychotherapist, and prior to working with RTI, have done a lot of work in the UK across really about embedding therapeutic practices into systemic models of care. So how do we take kind of what's in the therapy room and bring it more into practices and looking at the systems and kind of systems of harm. So with men in particular, I've worked in the UK prison system. I worked for many years with a lot of young men in London who've had very difficult starts to life, and have also done work with women, but we're focusing on men today.
Thank you. Hamza, let's have you go next, and then we'll finish with Daniel.
Right, hello everyone. My name is Hamza Al Said. I'm a physician in Hadassah University Hospitals in Jerusalem. Well, I must say that probably I'm the least experienced here in this field. I have really humble experience when it comes to psychological trauma. I've worked in the in Al-Quds Cognitive Neuroscience Labs. We basically ran research on post-traumatic stress disorder in patients who were in detention and who suffered all the catastrophes of the conflict in the region that I'm from. And yeah, that's pretty much it.
Hi there, I'm Daniel, as you can probably see. I'm not medically trained or clinically trained. My place here really is to kind of give the NGO perspective. I've worked with refugees in Poland, in Lebanon, and in the UK. I've also worked with people in immigration detention, which is where I met Theresa. And I've also worked for a couple of different mental health NGOs, primarily doing engagement work, trying to figure out exactly what people wanted from their mental health services, and then trying to pass that on up the chain. So I guess that's the angle I'm bringing tonight.
Excellent. Thank you all so much for that. And I want the structure of this webinar. We've done a couple of different types of webinars at Insight, and I'm hoping that the structure of this webinar, because this is an area of mental health and a type of topic that I think is going to be really fruitful if we have more of a discussion. And I encourage people, instead of just answering the questions straight out, you could feed off of each other's ideas and off of what other panelists are saying. And see, I'm hoping personally, as a professional, as a health professional, and as a humanitarian actor, that I can learn a lot from what you guys are talking about from your different backgrounds and perspectives this evening. And so we're going to start with the first question, though, that sort of frames this within the topic of our webinar today. If for the sake of ease, if we can go in the same speaker order, I think that will be awesome for people just lending their thoughts on that. And so starting with Theresa, so in your experiences as a professional, how have you seen cultural differences impact the way that men receive mental health care in the facilities and different organizations that you've been working with?
I've thought deeply about this, and the conclusion I came to is that it's not about the culture, it's about the sex, and that men are just culturally, whatever culture they're in, I think they are programmed, perhaps by genes, but certainly by the culture, to respond in a particular way, and that it's being a man that makes a difference. And I think that perhaps adds difficulty to receiving treatment or owning up or recognizing that they have a need for it, until it gets to perhaps an unhelpfully advanced stage. And it would be, more useful if they recognized it, if we recognized it early, and began some procedures to ameliorate that, and taught them some things and normalized it. So that's the quick answer. And certainly the people I saw in detention, and outside actually, who were in the UK, the people I saw were at an advanced state of needing treatment, and so there was no hesitancy about getting involved, because they saw me as a hopeful key to regaining some control. So that would be my sort of quick and dirty answer.
I can follow on from that. I have a somewhat similar view, that I think that the, culture affects all of us, and culture is hugely influenced by so many different aspects of our existing. So I don't, and culture is fluid and ever changing. So I don't think there is a kind of defined culture in the way that sometimes it gets referred to. And it's very important to see identity as a kind of constantly evolving, or us all having multiple identities and multiple stories, and stories that change sometimes daily and multiple times within a day. So I think that what you can often see is the way in which how people have experienced growing up, or their influences, whether that's kind of country related or family related or sect or religion, can have different impacts on expressions of emotion, expressions of grief, expressions of processing. And you do obviously sometimes see kind of consistencies with people from certain places, but you also see huge differences. And I think that's to do with human nature and to do with personality and experiences in life. I kind of similarly think that there are gender kind of impacts on gender from certain cultures that are different in terms of like how welcome you are to express vulnerability. And that's something that I think all over the world, not everywhere, but in lots of different contexts, men in particular kind of internalize a message that feelings are not welcome and that it's a sign of weakness, and vulnerability becomes increasingly scary. But I think in terms of cultural differences as well, there's also cultural differences in terms of treatment and the spaces that you go to, and, you know, depending on where each of us on this panel, but where people kind of mental health practitioners come from can depend on the model that you're trying to invite someone to. And if someone's not used to that because that's not kind of familiar to them, then there may seem to be some resistance, but that doesn't mean that they're not open. It might be that they have a different way of exploring or expressing what's going on for them.
Yeah, so regarding, I think it's I totally agree with what has been pointed out, and I honestly think that it is a combination of both the gender related factors along with the cultural differences. As we know, men are less likely to actually seek help when it comes to their mental health when compared to women. However, in certain cultural backgrounds, I've noticed that men are really limited when it comes to access, and along with their actual intentions and actual they wanting to basically go and seek help. Most of the times, most of the men that I've encountered in my cultural background or in the region that I've been working in, most men did not really seek mental health help when it comes to their psychological state, because of certain cultural thoughts and something that has been implemented in their minds. I don't know, it can be influenced by a lot of factors. It could be gender, but I think it's basically a combination of both. Most of the times, men don't really actually have the insight that they are actually suffering mental problems or mental health care issues. A lot of men that, for instance, that a lot of refugees have been actually objected to what we called a learned helplessness model, which means that they actually get subjected to a lot of trauma, consistent small amounts of trauma throughout their lives. And when they reach a point of basically outbreak that hey, I don't think that this is a problem, they actually think that this is the normal way of living. They stop actually responding to punishment and negative cues. And I think, like I said, I think it's a careful combination between both factors, and it really depends on ground and the area what we're talking about, and of course the level of education and access to healthcare. Because if we're talking about someone who's basically privileged and provided with so many resources to actually be able to seek help, we might see some sort of a difference when it comes to males. If we're talking about someone, for instance, if we compare that to somebody who has been living in a refugee camp for the rest of his life, the perspective of mental health in this scenario would actually differ. So yeah, I think it's a combination between both.
Yeah, I think that's a really good point. I think a lot of good points have been made already. And of course, it's true that gender plays a huge role in access to and perception of mental health treatments. But I understand that that's the next question. So I'll talk more now about the cultural differences instead and how they impact the way that men receive mental health care. Gabriella, I really liked your point about the fluid nature of identity and culture. I think that's absolutely right. And to a certain extent, that makes it difficult to comment in it or give any kind of definitive statement on given areas or kind of identities and intersections of identities that may have a given impact on a person's willingness to seek support. But I still think we can make some statements. I still think there are some things that we can say, even while acknowledging the kind of fluid nature of identity and culture. I do think there are quite significant cultural differences in the perceptions of mental health and the perceptions of treatment for mental health. And when I say culture, I don't specifically mean ethnic or national culture, although those are both really important. But there are many other types of culture that have an impact on this. So, as I think has already been mentioned, there are very different perceptions in different religious institutions. Some religious institutions will very much encourage a person to seek support. Others perceive mental health support in general as a very harmful thing. So, I think that can have a huge impact as well. I also think there are cultures within institutions as well. So, for example, within detention centres, which generally take a very prison-like atmosphere, they're often constructed along the lines of prisons. They're often treated as prisons by locals, by organising officials, by the local government. And they often have a similarly tough atmosphere within as well, and that can create a real trouble or real difficulty for a lot of detention centres, especially those which are male only, because people there will often feel they have to be seen as strong. They have to come across as able to stand up for themselves in order to avoid persecution or bullying from others. So I think that that kind of culture can also have a real impact. In terms of other cultural effects, I think that there are definitely places where it's actually seen as weak to have a mental health issue, or even just to be struggling with your mental health in general, even if it's not a medically diagnosed mental health issue. Just simply to be struggling with your mental well-being can be seen as a weakness. And there's an element as well of education there, I think, because obviously every area's education system will focus on different things. There are definitely different areas where mental health is actually covered quite well within the education system and others where it really isn't. The last thing that I would say really affects the ability of a person to seek mental health treatment or to seek support is actually more about social pressures, insofar as the way that people interact with each other is obviously and self-evidently different from place to place and in different cultures. The ways that men and women are permitted to interact with each other may vary, and the ways that men can interact with other men also varies. And I've been in countries where it is entirely permissible and normal for male friends to hold hands while walking down the street, for example, where there are other cultures where that would very much be seen as two people who are in a romantic relationship, for example. And I think that kind of ability to offer each other social support, whether it's tactile support, emotional, verbal, or even action related, I think that can have a huge effect on a person's mental well-being. Because it means that you're not quite as isolated. So personally, I think that has that's a really important cultural impact as well.
These are really good points and really important points too, because I remember, at the beginning of my career, without an extensive medical background, coming into these situations and not maybe making assumptions about the types of cultures that people were bringing with them, and not thinking so much about the types of cultures that people are coming into. And so it's interesting now, I'm back in Greece, I'm working with the same group of people that I've worked with before, and to see sort of the evolution of people's perceptions about lots of different things, but including that ability to be vulnerable or openness to be vulnerable or talk about emotional struggles or emotional hardships and even broach the conversation of mental health, to see people along different points in the migratory pathway be more receptive to that than they are at other points is interesting. And something else, there were a couple of key words that kind of came up, but Hamza said access. Access, I think, is also a really huge issue. And I think the only thing that I've sort of noticed in my work anecdotally that wasn't brought up with this is I think that language kind of shapes culture and culture shapes language. So the words that we use and how we use them are heavily influenced by the people around us and the way that we were brought up. And something that's been really interesting for me when I'm trying to find mental health services for certain patients is the language that they want to use to seek those services in. I think that's actually fascinating, where I make an assumption that like, oh, you're going to want to seek a provider who speaks Arabic because Arabic is your first language, but people saying, actually, I've learned how to talk about my mental health in a different language. And so I want to seek support and care for that issue in that language that I'm sort of like, that they have the vocabulary for. And so I thought that was kind of the only thing that I think no one touched on that I wanted to add real quick before we move into the next question, which is touching on gendered differences. And I think everyone kind of brought this up a little bit in their comments, but can anybody identify some of the gender differences that we see in mental health? So not necessarily the provision of mental health, but in the overall perception of mental health and presentation of mental health issues. Theresa, we'll start with you again, same order.
Well, I think it's safe to say, and there was a WHO report on this, that I think the main thing that we probably see is that women deal with their mental health by turning inwards with anxiety and depression, and men turn outwards, and so often are presenting with drug dependency or alcohol issues. And I mean, just as a broad just as a broad view on that. Now, whether or not you, in the sort of places that you're working in Greece, a lot of people, do the men have access to drugs and drink? Probably not. And then I was thinking also, of course, women do a lot of self-harm as the way to deal with it, whereas men are violent. Well, you know, men can express their distress by being violent outwardly rather than inwardly. And I suppose the people I was seeing in detention center particularly, they were at a stage where, because of the kind of, I don't know, the inbuilt spirit of determination to thrive, I think that they were all quite ready to talk to me and be heard, because they thought I might be able to help in some way. And so being very sensitive to the language and the way they're expressing themselves and their actions, and sort of matching that to find a way of communicating, was very important. But I think the presentation of the problem, again, differs quite significantly with the sex of people you're dealing with. So again, that's sort of broad brush.
I was going to make similar comments to Theresa. I think, you know, just to pick up that I don't actually know the statistics in Greece, although there is increasingly more information coming out about the kind of mental health across refugee camps, but suicidality is very high, and I think particularly high in men, and I think that's something that certainly in the UK I know is the case, so that's a kind of a big gender difference. Yeah, and a kind of tendency, and I think this comes from a normalization around like what's acceptable for men, which is violence. So I think that not to say that women aren't violent or cannot be, but I think that kind of outward expression, especially kind of when fueled by alcohol or drugs, is something that's like much more commonly seen by men as an expression of bottled up feelings. And I agree with Theresa that you see a lot more. I think depression, anxiety is ubiquitous, but the kind of turning inwards against yourself, so you're often seeing more eating disorders, and kind of internalization of rage and depression in women. I think there's something, again, and this is different in different parts of the world, and I do agree with your point, Daniel, that obviously there are you can comment on kind of culture, but I just guess my point is that there's often at an epoch in time, so you might see a kind of culture that has developed out of a group of people's response to ways in which they have been treated over many years or decades or centuries, kind of manifest in something that we call culture, but I'm not, but actually that can be a response to circumstance, but not to say that you can't see it, so I agree with that. But I think there's something around, and maybe this is a kind of men are from Mars, women from Venus stereotype, but that, women, there's a tendency more for women to talk and to share experiences, and for men to do that less so. So I think often a gender difference is, you can see the kind of like bravado, or in certain parts of the world, the kind of more laddie kind of culture where people are expressing something, but it's not really connecting to feeling. It's kind of often pushing outwards, and I think women tend to have more of a shared experience that they talk about, and then a language can develop through that, and then they're like, oh, I'm not alone with this. So I think you start to see those differences, and when you do create safe spaces for men to share about their experiences, I think often I'm finding that opportunity and relief and normalization of like, it's these, of symptoms, but also, oh my God, I can actually talk about this and it's welcome. Is an even bigger sometimes response than you see with women.
All right, I agree with all the points that have been pointed out, but I think that since we cannot really identify some major and obvious differences when it comes to brain structure and physiology between the two sexes, in the sense of mental health, I think that the difference of the gender differences come down to 3 points. When we talk about the underlying factor, which I think Theresa has explained beautifully, when we're talking about men, they usually tend to be objected to more alcohol abuse and along with substance abuse, and it depends on the type of the trauma that we're talking about, whether it's physical trauma, whether it's detention. So I think the type of trauma, the type of stress that is implemented on the individual actually might it's obviously different between males and females, and I think the second aspect of these differences is the help-seeking behavior. This is an obvious difference that is really significant between the two genders, and like I've said, women are more likely to seek help when it comes to their mental health issues, and of course, the third part would be the social consequences. If we're talking about females in certain cultures, they will have more of a harsh social consequence when it comes to their mental health. But in other cultures, for instance, in the Middle East, when a male tries to express his need for help, for mental health care, he will be more likely of actually being encountered with a negative consequence and a social bullying, let's put it that way. So I think it depends on these 3 factors: the underlying factor, and along with the social consequences and the health-seeking behavior between the 2 genders.
Yeah, I feel like a lot of what can be said has been said already. I think you've made some really good points here so far. I'll just add a few quick things. I think the first is that within the context of refugees, there is a huge disparity in the number of NGO projects and services that serve refugee men, as opposed to those that serve refugee women and children. And obviously, I'm not arguing that there should be less serving women and children. That's hugely important as well. But nonetheless, I think it can both come across to the men in camps that that maybe they aren't seen to matter as much. And it can also be a lot harder for them to access support simply because there aren't a lot of those services available to them. I also think that, again, with regards to the refugee experience, especially for those from cultures with more strictly defined gender roles, I think it can be a lot easier for a male refugee to lose perhaps part of their sense of purpose than a female refugee, insofar as in a culture with stricter or more defined gender roles, you'll generally find that men are expected to work and to bring home a salary, and women are expected to bring up the children and keep the home nice. And if you have a whole family in a refugee camp, then the mother may well find that she still has at least some degree of purpose to keep her going. And of course, purpose is hugely important to mental well-being. Whereas most refugees not being allowed to work, then the men won't really have that same sense of purpose within a camp. So I think that can be a real gendered difference between men and women in refugee camps. I also think, and this is something where all of you clinicians on the panel may be able to correct me, but my understanding is that whereas physically the male body is often taken as the default, insofar as, for example, people are far more aware of the symptoms of a heart attack in men than in women. But I think that maybe a lot of people are, sorry, let me rephrase that. I think that when it comes to mental health, maybe the female experience is taken as the default, to a certain extent at least. I think it's a lot easier to diagnose mental health difficulties in a woman than a man, simply because a lot of the symptoms that we look out for tend to be more those that manifest in women. And obviously I'm generalizing here, but on average, I think that's probably the case. And I think that also applies to what you were saying, Gabriella, about men committing suicide more as well, which is of course true. I completely agree. And I think the converse of that is that that women attempt suicide more. And yeah, and so I think that that's a really important gendered difference as well, and speaks back to what you were saying, Theresa, about the way that mental health difficulties in men are more likely to manifest in kind of forms of violence. And because men, if they are attempting suicide, are more likely to use a violent method, they're also more likely to succeed. And I think my final point in this is, how do you treat someone who is in a situation which is continually re-traumatizing? Whether you are living in a refugee camp or a detention center, or even if you're living in a flat or a house, or in slightly, if you're in a slightly nicer situation accommodation-wise, but you still have no idea whether next week you might be deported, how can you possibly be treated for severe mental health issues if you are constantly being re-traumatized?
Can I come back? Can I, do we want to move on to the next question, or?
No, please, if you have something to add, please, I want it to be more discussion-like, so go ahead and respond.
Okay, there's lots of different things, but I think that's a really interesting point, Daniel, that you make around roles, gender roles, and I can and have seen what you're saying play out. I think also, caring sometimes as a woman for your family when the provision is so far from kind of what you're used to, and just in terms of like community, village aspect, that can bring up all sorts of feelings. And I am noticing in the context we're working a real high incidence at the moment of this kind of psychotic episodes for women, kind of and as a kind of build up of the trauma. But I think kind of connected to what you were saying about gender roles for men is, or just to add to that, is that this, in countries or communities where there is an expectation for the male-bodied person to be the breadwinner or the provider, the pressure that the men that I am working with, for example, experience in not being able to do that in a context, and especially, for example, in Greece, the as in many kind of Balkan route, kind of transitory route countries, where there are very hostile environments, and there is not kind of systems set up to support people to find work when there's a huge will for that and huge skills and assets that could be put immediately into place and kind of benefit both the individual and the family and the kind of socioeconomic country context. And I think the impact of that is really, really huge on the psyche, and can feel very, the pressure of it, the kind of emasculation in some ways for some people. So I kind of really add to that as a gendered impact. I think it just in regards to your last question to us, and this is something that RTI is kind of, this is the foundations of what we do, is to recognize that actually what you can do is develop regulating practices that support people as they continue to be on a journey and aren't necessarily set up in a kind of static safe space, which is hopefully the end or the end point for a while. And what you can do is really work to help the body, help people to feel safe again in the body through kind of regulation. And I think this is an absolute at the core of trauma practice, which is like developing a sense of safety in the body. And I think, you know, we're already, sorry, we were challenging here, but we're using kind of pathologizing and quite Western Eurocentric language on this call about kind of treatment and patient, and actually a lot of the practices we use in terms of collective healing are regulating, have the impact of regulation, but they're from cultures kind of all over the world, and wisdoms, kind of indigenous wisdoms through the history of time all over the world, using music and movement and storytelling and rhythm, kind of refining a sense of the safety in the body through kind of different aspects of touch and play. And I think that is something that you really can do, and through the creation of safe spaces, and ideally safe spaces where people can speak mother tongue if they choose to, there is a lot of healing that can happen, and the relationships can build there, where if somebody needs some additional support, hopefully, and often we know this isn't the case, but you can find kind of referral pathways into more specialist support. But I think there is a huge amount that can be done by way of healing and regulating trauma without landing.
These are some incredible, excellent points. And so there's actually a question in the box that I want to address before we move on to sort of the next theme in this webinar. And for all of the attendees too, if you have any questions that you would like answered, go ahead and ping those over in the Q&A box, and I'm moderating that as we go along. But someone asked a really interesting question that relates to this topic and discussion of gender. How do your assumptions on gender-based differences account for those who may be non-binary or gender non-conforming in these contexts and situations? And we can either go in order if everyone has something to add to that, or we can just speak. Anyone who has any thoughts on that or experience is welcome to sort of take that one as well.
Well, I guess that for convenience, we tend to polarize things. But of course, the fact is that there's a whole spectrum here. And so the role of the therapist or the supporter is to find out where that person is and use language and resourcing as appropriate. So like, you can't know everything about every person or every culture. So being with the person where they are, and being open to finding your assumptions may be horribly wrong and being humble about it. You know, I think this is ordinary therapeutic practice. But, you know, the point is made that perhaps we're a bit easy using this polarizing language, but, you know, we are sort of quick in assumption making right here. So I apologize if anyone's been offended, but I recognize that there's a spectrum and we have to be flexible and deal with that.
And I actually want to stop and emphasize that, because I think that, you know, that's one of the main things that I wanted people to kind of take away from this webinar. I think that something that people have said in their answers so far when we're talking about the difference between gender and what different genders are offered when it comes to access to healthcare, and also the space and the freedom to express their mental health concerns and issues. I think we it almost illustrates the bigger problem here, which is that we're operating in this system that's not really designed to accommodate the range, or as you said, Theresa, the spectrum that mental health issues, and what Hamza also said of the underlying factors. I also think that's really important, is to address or recognize at least the role that the underlying factors have in the type of care that people are going to need, the willingness that they're going to have to seek that and to be then receptive to it. And then also when we come up with these sorts of, you can't create that like one size fits all when it comes to this, whether that's by gender or by the individual or the culture that we're talking about them coming from. I actually think that is a really important point to make about this topic as a whole. And so if anyone has anything else to add to that, go ahead and unmute yourself and go ahead. Otherwise, we can move on to the next topic here.
Let's just quickly add that, yeah, I mean, I completely agree with what both of you have said, and there are definitely different cultural perceptions of gender and gender nonconformity. The only other thing I'd add is that there is inevitably a greater incidence of difficulties with mental well-being with people who are gender nonconforming, and also with people who are trans and so on. And that's something else that we need to be aware of. But as Theresa said, fundamentally, all we can do really is listen to and hear and believe the person when they identify themselves, and possibly, even if they would like to, just discuss where they feel they might sit on that spectrum, because all the different things we're talking about today are applying to these generalizations of men and women. And some people may feel that, you know, some non-binary people may feel their ways of thinking and feeling lead more towards one and the other, or the other, and some may feel they sit somewhere in between or are nowhere in relation to any of that. And all we can really do is just hear them and understand them.
Yeah, definitely a very good point, Daniel. Thank you. Okay, so we're going to move on to the last question here, which is sort of, this is always my favorite part of a webinar. We spend all this time talking about problems, and now I kind of want to move into solutions. And so the last question that we're going to finish up here, I'm going to ping it to you guys, to the panelists in the chat. Are there any factors that you guys can identify in your work, in your research, in your lived experiences, or even in your personal experiences that you think need to be addressed so that we can help promote better mental health care when it comes to displaced males in particular? And Theresa, we'll start with you again, if you don't mind.
Well, certainly, I think if we're going to go deeply into therapy, then where these people, these men are, is not the place to do it. And so when I was working with residents with PTSD, we spent a lot of time on what we called stabilization and resourcing. And I would often talk to the men in detention about taking back control, meaning taking back control of your mind. So learning to recognize early on when the symptoms of panic begin to arise, and teaching them how to breathe, and explaining that they can turn the tap of adrenaline off if they recognize it early and breathe. And so some simple self-management techniques, I think, were very important. And I would ask them questions within their culture of, like, what would be an image, or what would the ancestors say, or what would the village chief say, or in your language, tell me the word for, I don't know, resilience or courage or taking charge, and get them perhaps to repeat that word several times with some emotion, so it became a kind of talisman. So just anything that resources and helps them take charge of their minds with explanations, so that they are given the power of knowing what they're doing and why. So it's not just some Western idea, but it's also normalizing that this is how the body reacts, this is how the mind reacts. And you may think there's not much you can be in control of, but actually you can control the way you think, the way you respond, if you are sufficiently aware. I mean, in a better situation, one would be teaching mindfulness, but you know, this is sharing some elements of that. And I think working in groups of people who share the same difficulty, and ideally, perhaps if it could be led by someone with that issue. Like I facilitate workshops for people with blood cancers. And one of the powerful things that and people like, because I am one of those, and I am at a second level of treatment. So, you know, it immediately creates a dynamic that, oh, wow, she's got it. Well, we can talk about it then. So I think having I mean, in organizational psychology, you'd perhaps call it a plant, but, you know, someone with lived experience in there helps in the group. So that's me briefly.
I echo everything Theresa's shared and can only really build on that. I think, you know, touching on Theresa's your last point around lived experience and kind of a shared experience, I think it's incredibly important. Yeah, I think that's incredibly important to have people who share an experience or from your, well, you said this, Maddie, actually, sometimes people do want to share something in mother tongue or do want to speak to someone from their community and sometimes they don't. But I think having the options, because different people have different needs, is incredibly important in terms of relatability and access point. But I think that relates to, so generally, I think this is for kind of displaced men, but generally working with refugee communities is us, you know, the mental health, and this is for the mental health sector generally, as being more identity informed, thinking more about the relationships, the dynamics in those relationships relating to identity, thinking about the unconscious biases, the assumptions that we all have as a human tendency about another, and what might we be projecting, and as practitioners really having a self-reflective practice and making sure you're set up to develop your awareness about who you are, who I am, who we are, what we're bringing, how that might be influencing how much somebody feels able or willing to open up and journey with us, because those processes block willingness. If there's a lack of understanding, and if somebody, maybe Theresa or someone else, really used the word humility earlier, this is a lifelong journey. This is something that, you know, we're always practicing all the time, and we're going to make mistakes. And, you know, similarly, if we have upset anybody today, then I'm deeply sorry. And it's a learning process around, you know, how you start to explore certain subjects with people, the kind of question points, but it's also having the courage to try, and then the sensitivity and humility to learn. I think particularly thinking about the communities that we work with, that for me, the starting point is creating community spaces or safe spaces where people can come together and relationships can start to build. Those can be relationships between group members, they can be relationships between facilitators or people setting up the space. But I think there is a sense of safety, a sense of often fun and respite and kind of a break from the everyday space. I don't think, sometimes people know that they need something, they need some directive mental health support, but a lot of the time, actually, people need to start relationships so they can start having conversations and start to have a sense of trust, and through that, you know, people then might open up about what's going on for them, or you might invite somebody into a space which is more therapeutic. And, you know, we have found that actually getting referrals, and so one of the things that RTI does is we facilitate kind of collective healing therapeutic groups for men, which are talking based, and women movement and art space. And it's been really hard to get signups, which you wouldn't think is the case, given how many hundreds of thousands of people are kind of living as refugees in Greece, and the fact that it's being offered in different languages. But actually the people who've come into the groups and stayed are when a relationship's been forged and we've got to know each other first, and then I've said, hey, you know, we've got this going on. So I think that's really crucial, and community building. And I think there's the ripple effects that happen then, which is you work with one person, they have a different language or a different relationships, their feelings, that can have an impact on family, on social circles. Sometimes we've worked with groups where there's close friends that have decided to be in a group together, and they have conversations in that group that they've shared they don't have outside of outside of those group spaces. So yeah, I could go on, but I'll stop there.
Yeah, I really do agree with all of the points that have been pointed out. I just wanted to talk about the constants and variables when it comes to displaced men. When we're talking, there are some factors that unfortunately are really hard and difficult to change, which we all agree on that, whether somebody is stuck in a refugee camp. And like Theresa said, you cannot really help these people if they're stuck in that place or in their causative kind of agent for the rest of their lives. So there are some factors that are kind of difficult to change. We need to address that. First of all, we need to just be convinced that these factors are going to need more time to actually kind of switch. But there are some variables that we can always target. These include awareness and education for these displaced men, because most of the times it's caused by the lack of awareness, the lack of insight. Let's put it that way.
Mm.
Like I said, when people are subjected to an ongoing trauma for long periods of their time, of their lives, they actually tend to develop that. So awareness is a really important keyword here from my perspective, and it actually implies for both the patients, the displaced men, and along with healthcare providers. Unfortunately, most of, not most, I'm going to say a lot of healthcare providers are not adequately trained when it comes to dealing with patients who are people who suffered really severe trauma in their lives. So I think we need to develop training programs, or at least when it comes to medical healthcare professionals, we need to make sure that these people are actually capable of dealing with these issues that they might encounter in their daily patient care, and especially when we're talking about displaced men and refugees in particular. So from my humble experience in humanitarian work, I would say that unfortunately a lot of us, including myself, was not really that involved and trained when it comes to the mental problems that these people might have. And most of the times it's just you're pretty robotic, I'm sorry to say, when it comes to such stuff. This patient has a rash, this patient has a disease, I need to do this and that. And we don't really pay attention to the small details that actually matter. And actually, I think these are really significant when it comes to their mental well-being.
I think that's a really good point, Hamza. And it kind of feeds into one of the points I was going to make, which is that in answer to this question, I think that we really need both more awareness of this at the training stage, certainly for doctors and counsellors, but also for essentially everybody else who is going to come into contact with refugees. So Home Office officials, people who work in camps and detention centres should be getting much better mental health awareness training than they're getting, that kind of thing. I also think we need more academic research around how mental ill health manifests in men and how it can be diagnosed if men are more likely to be trying to hide it, for example, or are more reluctant to acknowledge it than women are, very much on average, of course. And then I also think we need these findings to be disseminated much more into medical training, because, and again, you may be able to correct me on this, my understanding is that sometimes, at least, there are really good studies that are done, psychological studies that are done, which are then maybe not incorporated into medical training as thoroughly as they could be. I also think we need, and this is relating really to a point I made earlier, we need more NGO services for men. And of course, we need more for everybody as well. You know, we need some that are not restrictive in who they serve. But given how many we have that serve specifically women and children, I think it's really important to have more services specifically for men as well. And I also think we really need more social support for men as well. I'm not just talking about mental health services, but also social services, social clubs, social get-togethers, things that emphasize the importance of forming relationships, because this is very much, I think this is a key factor in mental ill health, especially in older men. Well, not necessarily older men, but men as they get older. I think because men tend to form the majority of their close friendships quite early on in life, possibly at school, possibly at university, possibly in their early working years. And it gets harder and harder to form significant relationships as you enter your 30s and your 40s and so on. And obviously that's made so much worse if you've been forced to leave everybody you care about behind and you find yourself in a situation where you're surrounded by strangers. So I think that kind of social support and emphasis on the importance of social support is something that we could really be improving on.
These are excellent points. And for those who are attending or watching, and even panelists who aren't familiar with some of the work that we do at Insight Collaborative, one of the projects that I work on in partnership with another organization, and the one that kind of inspired this initial theme for this webinar, we have a project called the Brothers Campaign that kind of highlights the overall, and Daniel touched on this a lot, but the overall shortage of attention that's given to male migrants. And so a lot of the work that we've done in our research has been kind of both stigma work. We have a researcher who's really experienced in researching social stigmas, especially with post-immigration populations, but also, you know, how does that then manifest? How does that affect them when they're internalizing these messages that these new host countries are sending them of, you know, you're coming here with all of these problems. We don't recognize the complexities of your traumas. We don't acknowledge them. We don't give you space to address them. We don't give you accesses to resources. Even if you want to heal, they're significantly limited. But then, you know, at least in a family dynamic situation, or for some of the single men that we have under our care as well, they look across the way and see like, oh, there's a community center for the women. And my neighbor just got put on a really successful pharmacological regimen that's working really well for her, and she's happy with it. And then, as Daniel brought up, which is a really important point, the lack of overall research that is done on this, and then the amount of that research that then trickles down to the point of it being put into practice is dire. And this is something that I really do think needs to be addressed. And so I think these are all excellent calls to action and lots of really good things for people to be thinking about. And so I am cognizant of the time, and I'm just keeping an eye on the question answer box. And I actually think that a lot of these questions were answered in some of the other answers that you guys had to the main guiding questions. But there's one that proposes something that Gabriella briefly touched on, but I think we could elaborate on a little bit more, only if people have time. And if you don't, you're welcome to sign off and part ways with us. But this question asks, what are some of the ways to increase individual and community capacity for healing in a way that empowers the community rather than creating dependencies on historically and often still majority Western aid organizations, especially in transient populations? That one's kind of long. I'm going to ping that in the panelist chat here so that you guys can see it and read it. And if anyone, I'm sure, Gabriella, you might have something to say to that, because we've had sort of we touched on that in our initial meeting. But if anyone has any thoughts on that question, please go ahead and unmute yourself and take that one.
I can start. Ways in which I can speak kind of from the perspective of Refugee Trauma Initiative, which is, you know, RTI was founded by someone who, with her family, was a refugee from Afghanistan, and that has like deeply informed the whole kind of model. And from the board and governor level to kind of our current team members, there are people who have lived experience, current and past, of being a refugee. And we work directly with communities to co-create kind of the programs and materials. So the spaces and the kind of concept of the spaces and how and why they're set up are fully informed and co-created with the community. And then we work with the community, we provide like livelihood, we provide training and jobs, and the kind of spaces are then led by the community as well. In this case, one of the people who have been displaced, fleeing war and conflict. So I think that's really important. Kind of other ways that we try to challenge the kind of aid model is really look at kind of training programs that are multi-year. So we don't think you can go and do a training program in a week and then kind of go and deliver it and then leave. It's really about a kind of development of a relationship with a community, developing facilitators over time, where you start with a community space. You know, often people don't know each other when they're living in a new area, so you need to create an opportunity for people to come together and get to know each other. And sometimes that does mean you going in, or you being the kind of local organization, whether it's kind of local Greek in this context, or refugee led, and starting to create a space where relationships are built. But then over time, as relationships build and as you get to know people in the space, so with our Baitner early childhood model, the caregivers start to be part of the facilitation or kind of delivery team. So they're kind of bringing in their practice, their experiences in all sorts of different ways. And then what we've seen is offshoots of programs create. So one of our partners does a kind of eco salon, which is a women's space, which is, you know, just for women to come together, and then they decide lots of different activities they do, and kind of talking groups have come out of that, or beauty salons. But really, people through meeting each other start to create spaces where they know what they need and create it for themselves. And if they want to ask the original team to be a part of that, then they sometimes do, or it's about using the physical space. So those are some ways that I think are really, really, really important, as well as on a systemic level, challenging the kind of Western Eurocentric imposition of like how we see mental health and healing practices.
Mm.
If no
Yes,
one else has
I'm
anything. Oh, go ahead, Theresa. You go ahead and go first.
I was going to say I'm not sure how this would work, but understanding and perhaps keeping an eye on what is the motivation of the people who are providing whatever the context or the service is, because you know, thinking about food banks, it's hard for the people who are receiving food to be offering anything back. It makes a very uneven relationship. And again, the other thing I was thinking about is you see programs about there's one in the States where you see ex-convicts who are training dogs that need socializing, and they are doing good things to each other. So again, there's an equality there. And so how do you make sure that both people perhaps acknowledge that they are getting satisfaction from it in benefiting the other and creating connection? Because if I'm getting all my, you know, enjoyment playing the rich white person, that is a bad intention. So I think knowing where you're starting off with and the people you engage in that project, there needs to be an understanding that there's great mutual benefit, and yes, so you can have this equality and more genuine connection and relationship. So there's no dependency and there's no superiority. And different people are bringing their different sorts of knowledge and experience, but it's enriching and enlivening for all.
And that, if you guys don't mind, is an amazing point to close on. And I think what I'm hearing from this, like everyone's answers from Gabriella and I talked for like an hour and a half on Zoom the other day. And I think that we dove into so many different avenues of what could be topics. And I think Daniel bringing up the lack of research that's going into the male specific issues that we're seeing with mental health care. And I mean, Theresa, your experience with detainees, that could be the mental health of detainees could be its own webinar. Like we could have 1,000,001 different webinars here with all of these different topics. But I think that's kind of an important point to close with, because something that, at least at Insight Collaborative, that we really try to emphasize is the influence of this, for lack of a better word, it's an industrial complex. We're still, even in healthcare as well, we're working in an industry. And it's really too bad, because industries and these capitalistic structures don't necessarily promote positive mental health and holistic healing in the way that people need, especially, you know, people entering a Western structure from a background, whether it's a culture or a context or just an experience that's different from that. And that maybe it's, I think one of the phrases that's come up a lot is like safe space and leaving space and holding space. I think it's important for us to recognize that that space is going to look different for people depending on what they're used to. And so there could be a lot of incongruencies in the spaces that we're providing, because we're not necessarily thinking about it the same way that other people are, or our motives, unfortunately, may not be correct and congruent with what the needs are. And so thank you all. I have to thank you all so much for your time this evening, because we've gone 10 minutes over. But this was incredible to have such a diversity of experiences and perspectives here. I learned so much from all of you. I hope to have all of you on webinars again. And I just want to thank everyone for attending and for asking such great questions as well. I'm sorry we didn't get to all of the specifics, but I hope that you guys at least got something that you can kind of work off of from some of the answers that the panelists had to the guiding questions of the webinar. So thank you all so much. I hope you have a great evening or day, whatever part of the world you are in. And I hope everyone stays healthy and safe right now.
And you too.
Thank you guys.
Very much.
Bye.
Bye-bye.
Hamza, go ahead. You're the host, so you can go ahead and end everything for all of us.
All right. Bye bye.
Great. Thank you. Bye.
Bye-bye now.